అంతా అయోమయం అట్లా ఉన్నది.
Good evening, sir. Deepraj, sir.
Yeah, good evening. Good evening, Ramkrishna.
గుడ్ ఈవినింగ్ దీప్రాజ్ సార్. గుడ్ ఈవినింగ్ సార్.
Good evening, Viresham. Good evening.
Good evening, sir.
Good evening.
సార్ లైట్స్
Sir, good evening, sir.
Good evening, Ravi.
Sorry.
మేడం ఏమన్నా కాఫ్ కోల్డ్ ఉందా?
Sir,
Also, throat infection undi.
Srilata, your throat is still bad?
Yeah, I told you, na, that my throat is bad, so it will be like interfering in between. That's why I'll make
That
it.
is why she couldn't become examiner today.
Yes, yes, sir.
I told you very clearly. When it comes for a longer time for me. That's why I know about it.
Namaskar, Bajwa, sir.
Namaskar,
Namaskar.
everyone.
Namaste,
Good
sir.
evening. Good
నమస్కార్
evening.
నమస్కార్ నమస్కార్ బాజ్వా సార్. వెల్కమ్ 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 టు యూ సార్. వెల్కమ్ యూ సార్.
Thank you. We had a very nice time during Telangana State Conference. That was a very nicely arranged. Everything
you
was
are-
meticulous.
yeah. Your friend has come as chief guest. We will remember like
Arey,
anything.
Naveen. He was my childhood friend. Right from the
Yes.
beginning, he was my classmate.
Yes
We
sir, yes sir.
together. And but it was, I liked what the concept was, that the simplicity and the magnanimity of the conference was good.
Yes.
There was no hi-fi thing, nothing, that sort of, and the ISA people performing the culture program and everybody participating, and the educated people being called for, and DRME was also the, I think, guest of honor at that time. So
Yes.
all the people who were called, and the things, they were very impressive somehow. You
Yes.
don't get these things everywhere, but now the trend has started in ISA, how to honor our own academicians and dignitaries who have done hard work in academics and society. I think
Yes,
that's
sir.
the way to go forward.
Definitely sir,
I
definitely.
congratulate everybody for that also.
Sir, I congratulate
So,
you.
Bajwa, sir, let me introduce our academic chairman, state academic chairman, Dr. Deepraj Singh is here.
Namaste,
He was
sir.
immediate past president ISA Telangana.
Good evening, Bajwa sir.
Thank you, sir. Same to you, sir. Good evening.
And Dr. Ratnakar is here. He is president-elect, incoming president.
Yeah,
He
yeah.
is
He was.
attending from United States.
Wow, great.
For
Great, great.
your lecture,
And
sir.
Dr. Viresham is well known across India
For many years.
since birth.
What is that statement?
And today's coordinator for the teaching program she is additional professor Dr. Srilata at Nizam's Institute of Medical Sciences.
Yeah, ma'am, I
Srilata.
know she has got a many number of publications she keeps sending to IJ, a good reviewer of also IJ also, and GOC.
And Dr. Bajwa doesn't need any introduction.
Yeah,
He is a hardworking, like all-in-one for IJA for the last 2 years. And his hard work brought us all the editions. So we will wait another 1-2 minutes, sir.
Sir, I am Dr. Ravinaga Prasad, sir. I
Yeah,
am
he is,
Associate
sorry,
Professor,
he is
Nilofar.
Dr. Ravinaga Prasad. He is working as at
Professor.
Nilofar Hospital, Usmania Medical College.
Okay, great, sir. Great to meet you, sir.
Okay, sir. Thank you.
So Ratnakar, sir, how is US?
Sir, you are muted. Ratnakar, sir, you are muted. Ratnakar, sir, was chairman with me, co-chairperson with me during the conference.
Oh,
Yeah,
is it? Very good, very good.
Sir, am I audible now?
Yeah,
Yes,
yeah,
yes.
You are audible.
Yeah,
How are
I'm
you?
at my son's. Yeah, very fine.
Oh, nice, nice.
I'm at Florida,
Hmm.
USA, at my son's house. I came for
Oh.
new housewarming celebration,
very great.
and it's very nice.
Congratulations.
The weather. Thank you, sir.
So he will give a big party. He will give a big party after coming to India.
Yeah, 23rd. We are
Anyhow,
planning
we
on
are coming
23rd.
we are coming to Karimnagar.
Welcome, sir.
Yeah. That's interesting. Correct.
Right. Okay.
And at Gurgaon, he will give a big party for us.
Gurgaon, sure. Anyway, this year is very, very pleasant, and very. Most of the happenings are very good. Everybody liked.
Yes.
So we are excited.
We are excited. Okay.
Because
carry
of
on.
long COVID period, and we have now started our
post-COVID.
get. Yeah.
Yeah. Yes.
So So I think we will start. We don't want to waste the time of all of you. So welcome to ISA Telangana Webinar Series. Good evening, one and all. President Dr. M. Veeresham, sir, and our academic chairman, Dr. Deepra, sir, and today's speaker, Dr. Sukhminder Singh Bajwa, sir, and Dr. Ravina Prasad, Dr. Srilata, Dr. Ratnakar, President-elect, Dr. Sherry Matthews, I can see his name, and Dr. Anuradha, madam. Everyone, welcome. Welcome to ISA Telangana Webinars. We are doing this for the past 2.5 years, probably just after COVID started, 2020, June. So we are continuing with a lot of efforts. I have a group of coordinators with me who are helping me, 4 people, and we are able to run as like you are seeing. So hopefully it will continue in future. So now I request Dr. Veeresham, sir, to give 2 words about.
Sir, good evening, everybody. We have gathered here. I welcome on the work, my bottom of my heart, Dr. Sukhminder Singh Bajwa, to the webinar. The topic selected is very, very good and very much useful for the young anesthesiologists who are doing in teaching faculty jobs. So I think he is perfect in doing his job. I will tell that he is the best among the IJ journal editors. Sir, over to you, sir.
Over to Dr. Srilata, actually.
I'm Dr. Srilata from NIMS, and I'm the coordinator for today's webinar. And our topic for today is bridging the academic gaps and striving towards publications during post-graduation and private practice in anesthesiology. As we all know, it's very difficult to sustain the academic activities when you are doing your private practice and also when you're doing his post-graduation. So this is, I think it's a very good insight. If you go through this lecture, that will be very good insight for all the private practitioners and all the postgraduate students. And to introduce Dr. Sukhminder Singh Bajwa, he is a professor and head of Gyan Sagar Medical College and Hospital in Patiala. And he has got a lot of achievements. And as already said, this lecture will be quite good insight to all the young anesthesiologists. So I would like to say that he has received the best young anesthesiologist of India, like KPR, in 2012, and also has got a best research paper in 2013. And as we all know, he has got a lot of credentials in both the national and international publications, and has authored 7 national guidelines in different subspecialties like anesthesia, medicine, and endocrinology, and also has got some chapters in his credit. And he has got a good number of contributions to ISA. He is the editor-in-chief of Northern Supplement of IJA, and right now he is associate editor of IJA and JSP. He's associate editor of IJA and JSP for the last 12 years. And as said, he has got a lot of credentials to his name. So I won't waste further the time, and I will just give the mic to Dr. Bajwa. He can continue with this lecture. Thank you.
Thank you, ma'am. Thank you for the so much nice description. Actually, it doesn't require that much. I just sent that the CV according to Dr. Ramakrishnan sir's requirement. It's okay. Just saying editor is good enough.
Yeah.
Rest I think don't require at this stage. The purpose of this, sir asked me to present this lecture. What we are feeling at the moment in ISA or even in IJA. Our practitioners are not inclined towards the academics. And moreover, forget about the practitioners, even our PG students. The teachers have to, give them a pressure, give them a push every time to publish in the journals or present the paper in the conferences. there must be some reasons why people are not, complying to our education, teaching, and our motivation also. There are so many things. This I have been looking for, I think, in the last 2 years. What is the basic problem about that? And I am in almost in a, I think, a ready state, that practitioners module that I will be launching in 3 months' time, where I think it will be very well, established in India. We have always been working on airway modules and research methodology modules, difficult modules, but we have never worked upon the practitioners aspect, I think, which almost constitutes 50% of our population. Till the practitioners are not involved into the mainstream of ISA, or I think the academics cannot progress. How much hard work, I think, in Nizam, I think a lot of hard work in Osmania, a lot of hard work is being done. Whether it is being disseminated to them, whether they follow those things, whether they follow protocols, whatever the requirements for the safety of the patient, for advancement of a specialty, I don't think so. There is a gap, actually. If you ask me honestly, there's a gap. We have tried so many times to bridge that gap, but it's not possible. So the ultimate answer is to develop a module which should be very practical and should be feasible to every anesthesiologist, the practitioner, as well as the PG students I covered, because this, I think, seminar is being viewed by the PG students also. So the whole crux is the publications, the research is ultimate. Whatever the clinical work we do, whatever we achieve in our life, in a professional life as an anesthesiologist or intensivist or a pain physician, till it is published, the things are not complete. The publication of the work is the ultimate, goal should be of everyone. So this lecture is basically focused on those aspects. Shall I start with that? With the permission of chairpersons?
Yes, yes, sir. Yes, you can continue. You can share your slides if you want.
Thank you,
There
sir.
is an option. Yeah, yeah.
Thank you, sir. Sir, is this fully visible or not? The slideshow is visible?
Visible,
Uh,
visible.
slideshow you have to click, I think. Slideshow you have to click.
Okay, okay. I think
Big, make it big.
Yeah, from beginning.
I will just,
yes.
I will just do that. I will just do that. Now, sir, it's visible, the slideshow. Ready, sir? Is it visible?
No.
Okay.
Only.
Sir, it is visible,
But not as a slideshow, na?
but
Yeah.
not as a slideshow.
You have
Yes,
to
yes.
make it big. That is what. That
Yes, sir. Yes, sir. Yes.
Only one slide should.
Okay, now it will be visible. I was just having one mistake only. Now it will be visible. Now it's visible, sir?
Yeah. Now it is.
Yes.
Okay. So, greetings from my own medical college, Gyan Sagar Medical College and Hospital Patiala, where I'm working. This is just a small part of that. There's a huge campus and a huge building. The entire lecture or talk or whatever you can say, motivational perspectives, they are dependent upon this figure. This was Maslow's hierarchy of needs, which I read during my MBA in hospital administration. And it was my favorite topic. The Maslow had clearly defined, he was an American psychologist, how the human needs really matter. Now, to every PG student as well as a practitioner, I will just say that all these 5 needs, see, these 5 stages of life, 5 rather desires and goals of life is, first of all, is physiological needs. like air, water, food, shelter, sleep, clothing, and reproduction. These are the very basic needs. I think still in India, many people are devoid of this thing. A 3 time food, or even many people are sleeping on the footpath. And clothing, I think we have seen so many times beggars don't have adequate clothes. So we as anesthesiologists, we have crossed this ladder right from the time we entered into the profession. Then comes the safety needs of a human being, like the personal security, the employment, resources, the health and property, all these factors. Once you have joined the post-graduation career, I think majority of us have almost achieved these type of needs, where the safety needs, we have achieved that status. From here, we go to the next step. I think right from the beginning of the third year, or even the second year, sometimes people start thinking to have a family, because the career is almost established. They have to appear for the examination, and then the career will start, the professional career. But that thing, all these things come into mind, like friendship, the intimacy, the family, the sense of connection, all these things, they're very much part of our life. The professional life is on one side, and these things are also on the other side. So love and belonging is a third ladder of the hierarchy needs, and where majority of our postgraduate students belong to. Once you pass out the post-graduation, now you have stepped into the professional careers. Maybe as a practitioner, maybe as a senior as in the institutions, or may have joined a corporate hospital. Now you are striving toward achieving the fourth ladder thing, that is the self-esteem and the respect as an anesthesiologist, which we are struggling still today to have a uniform respect for the country as intensivist. And that was very much visible during COVID time, but it has started diminishing again. So that is a status. What is the status of anesthesiology as a specialty? These things, may be a controversial or questionable or debatable, but we are still striving. Once we achieve this professional stage, that we vie for the self-esteem and whatever the freedom and the strength, all these factors, they constitute this fourth ladder. So majority of us, even I think not just after passing post-graduation, even after doing a practice for a lot of time, or you may be in the institution for a lot of years, still we are struggling to get this ladder cross, that is self-esteem. And last of all is the self-actualization. It's defined as a desire to become the most that one can be. That means it's rising above what we over the worldly things. The self-actualization state that maybe you're doing a practice, maybe in the institutions. I think even a teacher, a HOD or a senior professor will feel that by teaching the students, they have achieved this stage. That's actually the reason, because it gives you satisfaction, the inner satisfaction, inner peace, inner happiness. This stage is what we always, aspire for. And how it matters in the life of a postgraduate or a practitioner, this stage is very difficult to achieve. But I will still, give a salute to our postgraduate students. I think who just passed out last year or maybe this year also, who did very hard work during the COVID time, because in majority of our institutions, 70% of the anesthesia force was the youngsters. So I really salute to them. They did a very good work, and they helped in bringing a good acclaims to our specialty. So this self-actualization is what we have been always, yearning for. This is a very important stage. So the entire talk is basically aimed at achieving these stages: esteem and self-actualization. First of all, I will go to the private practice, private practitioners. Basically, there are challenges and limitations of anesthesia private practice in a country, which sometimes, they create a gap between the academicians and the practitioners. So practitioners on one side, they are doing a good service to the humanity, or maybe they are earning for themselves, but still, in our field, I salute to them, because in anesthesiology, whatever been taught in our during postgraduate career, the patient safety is the first. So majority of us, I think, aimed at patient majority only. But still, there are challenges. What are those? And these challenges I'm talking about in terms of publication. That's why this entire talk is based on which challenges are there which are inhibiting the publication. First of all, the biggest challenge is the insecurity among the practitioners. Maybe they're working in the nursing home, maybe the corporate sector, but there is always an insecurity among them that how much job is really, secure. Insecurity is there, the time availability, the punctuality, so many things. Then if you see the practitioners are working in the peripheries, especially, they are almost always alone and no helping hand. And they rely upon the teachings being given to them during the postgraduate career. How to save a patient, how can they be saviors of humankind? And there is no fixed salary for the practitioners. Maybe corporate, they're giving a fixed salary, but we are not counting them as practitioners. Practitioners exclusively those people who are working from nursing homes or working in the peripheries. There is a not fixed salary for them. And we have seen, we should not deny this. We should be accepting this. They have a minimal time to prepare the patient. They have been called when the patient is in emergency on the table. So they don't have adequate investigations to go further into the details of the patient. They have to take history, right? When the patient is on the table for any surgical intervention. And they have no time for optimization, and refusal of cases in such circumstances is a very difficult task. You refuse a case, next time the surgical team will not call you. So this is just a matter of, a survival for that particular practitioner. And planning of a family affair is a difficult task. Suppose I want to, I'm a practitioner, I want to go to Switzerland, or I want to go to any part of the country. Spending 4 or 5 days with the family is very difficult, because leaving the practice for 4 or 5 days and then almost enjoying the vacation is a very difficult task unless you have got a replacement for you for all your cases. But even then, there's an insecurity whether the replacement will permanently replace you or you just have to, they're very much reliable people. Then that's why the adjustment duties become very difficult for a practitioner to adhere to any schedule to going for a long holidays, because there are no fixed holidays. Even Sundays are working day. So there is we get, as academicians, we get the casual leaves, we get the gazetted leaves, but they don't have any fixed holiday. The challenges don't end there. There are furthers also. And invariably, these practitioners are, they face the situations which are very, very cumbersome. Like maybe in a gully or mohalla or some street, a small nursing home, they've got ill-equipped operation theaters which may have got a suboptimal atmosphere and resources as well, including the manpower. The important gadgets, the life-saving gadgets may not be available in those operation theaters. And there's a higher vulnerability to medico-legal issues in circumstances. Anything going bad, the anesthesiologist is directly incriminated into those things. Sometimes it happens less as compared to the institutions. This is my personal observation, may not be with everyone, but ego clashes with colleagues and surgeons do occur sometimes. And most important, now we are talking about the self-esteem and the self-actualization. Recognition of a practitioner is confined to local areas. I'm saying Hyderabad. Hyderabad is a big city, metro city. But a practitioner practicing in Hyderabad, is he known to anybody outside I think Hyderabad? I think, forget about outside. Is he well known to Hyderabad people? Is he known to the anesthesiologist fraternity of Hyderabad? I don't think so. So recognition is very confined for the practitioners. And majority of times they are at the mercy and whims of the attending surgeon. And this is the truth. And behavioral problems, our specialty is such, we are dealing with all type of complications, difficult cases, and difficult scenarios. The behavioral problems can arise. The marital discord is common. And I haven't added suicide. Suicide is, one of the studies of this one, British and Irish study, they've told that the incidence of suicide is highest among the anesthesiologist fraternity and substance abuse. And among all, the night call is the most stressful. For a practitioner, the night call never ends till he leaves the practice. And now, the most important part is all practitioners can say that they have no time for publication or there is no motivation them for to do the academic work. This is a very common thing now. Considering these challenges, and there are less academic opportunities as well. It's true, because in institutions you get opportunities, but not for the practitioner. So these are challenges are very much, prevalent. Now, some little consideration to post-graduation also. They also have challenge and limitation. If you ask a postgraduate why you are not publishing, why you are not publishing, why you are not writing the research, why you are not doing this thing, first answer will be, sir, ma'am, we have long duty hours. From where we get time? We don't get adequate sleep. Okay. Then, ma'am, we are also, busy in the studies, the thesis and research work also. We don't get time actually to go for the publication. And if you ask me honestly, these people, maybe first year, the second year, third year, postgraduate, they are new to these avenues of publication. And the biggest drawback in our country is the lack of research methodology knowledge. And it is not among the postgraduate, to be very honest, it is among the teachers also. The research methodology knowledge is incomplete. Till we have a complete knowledge of research methodology, we cannot go for the publication of the clinical investigation original research articles. And confidence levels vary. I think it's an individual thing. Every PG student may have a different confidence level. So it is a debatable whether they should go for the publication or not. The confidence always varies. And say distraction by social media. This is very common nowadays. If I ask my PG student, you go and search this topic, for at least for the research, because this topic is novel. You search all about anything related to this, relevant to this topic. They will go, once they start searching, immediately they will be start working on the WhatsApp simultaneously, the Facebook or Twitter or Instagram, whatever. These distractions have come up lately for the last, I think, in the last 5 to 10 years, which were not there previously. But in spite of the advancements in the social media, the distractions have also increased. And the motivation levels, they vary among each student. How much they are motivated. We teachers always try to motivate them, but it's individual. It's always an individual phenomena, how much motivation they really carry. And it also depends on the mentors. Even the mentors, how much they are motivated to, how they are prepared to motivate their disciples, I don't know. Because this is, again, highly variable in our nation. And if you ask me honestly, even we have started the mentor-mentee relationship awards or something like that, still it's not working. And most importantly, our PG students lack the future vision. That's what is the role of publication in their life. They may think that it's just a matter of publishing one chapter or one book or one, article, and that's done. No. They really lack the vision, because this is a stepping stone toward their professional excellence, which they will realize once they go to practice or institution. After 5 or 6 years, they realize they have wasted their time, the valuable time in which they were more productive. They could have done more hard work to get the things published, but they wasted those years. So the vision is not there among these. So in just in a limit, in a short, I say phases of private practice. I say a past postgraduate career, I've run a postgraduate examination, the practice. The first phase start the struggle phase when I start getting looking for a job in the corporate or in the private nursing homes, or whatever available to me, or maybe some diagnostic centers. After the struggle phase, when you get established, you get known to your particular local area, you get a golden phase where you have done, I think, after passing through a good institution like Nizam and Osmania, you have done good work in during your post graduation. Now you can handle all the difficult cases. You say you are in a golden phase because of the competency which have been imparted by your esteemed teachers. Now you say you are in a golden phase where everybody sees, everybody looks for you. Come, this case can be handled by you in a very good manner, because the medical legal implications are more nowadays. So they feel that this person, this anesthesiologist is good for our cases. And then come the last is the master phase. This is after a long time, maybe arbitrary, if you ask me, 25, 30 years, when you have really practiced, mastered the practice of private practice, where you attend only to those cases where you can really handle in your comfortable time, not for the night calls, because you have already earned enough that you don't think so there's a need for going for every case now. So these are the three cases as compared to this private practice. Even the post graduation also have three phases, like struggle phase. In the first year, you struggle a lot. A person coming new to the institution is facing a lot of teachers, suddenly he's under pressure of finding a topic for the thesis. Suddenly he has to get acquainted with all the surgical procedures, the protocols, had to maintain a relationship with so many things. I'm thinking like a first year student PG, I'm unknown, I'm unknown. So I have to make relationship, I have to get into the system. So this is a very struggling phase for a first year PG. And once that is acquired, then the second phase, you are in a most comforting phase. Most comforting means you will see your juniors coming to you below, it's not a ragging, but rather the juniors coming, you feel very much senior now. And, you are well acquainted with the OT atmosphere, the ICU atmosphere, or the pain clinics, or the PAC clinics, or the emergency department. And you know the procedures, how to handle them, but you're not that much competent, maybe, or competent or may not be, but you are in a comfort zone now. And you have got a seniors above you who will be helping you. So you are in a good relationship scenario during second year of your post-graduation. In the third year, I will call it a master phase, because here you feel that you have mastered the art of anesthesiology. Maybe a pseudo feeling, maybe a true feeling, how much hard work you have done during the last 2 years. Even the teachers depending upon you, that this person, this third year PG can handle the ICU, difficult ICU case, difficult operative case. So all the interventions this person can make. So that creates a master phase for you. You are now in a master phase. The reliability upon you increases during this year of your post-graduation. Now, again, coming back to the practitioners. No, if you ask a practitioners, why you are not motivated for the publication, the answers are very well formed. What the common answers are there? They will say, as compared to the academic scenario, means in the academic institutions, and they've got a, they say the teachers or the faculty have got a fixed time of, working. They've got a fixed time of maybe 8 to 4 or 9 to 3, something like that, whatever the time is there. And if you see, there is a hierarchy in the system, that a person right from the beginning, when it crosses a certain age or certain barriers, they are promoted, and then they become the supervisors, administrators. So hierarchy works, and they have got a less burden. That's why they are more into publishing. And they've got a fixed salary and the regular increments in pay. Whereas in a practice, you have to work every day, every hour to earn for yourself. And another thing is that faculty gets a residential quarter to stay. That is a free of cost accommodation in many parts of the country, especially in the private medical colleges. Then they have vacations to enjoy. We don't have vacations to enjoy. They get a vacation, so they can always, utilize their time for publication. How can we? We don't get vacations. And the resources are optimal, and team is invariably there in the institutions, not in the practice. They are alone. So this is a valid point. I agree to it. And most important is there is an immune cover of the institute or the hospital to the practicing academicians, not to the private practitioner, because anything happening in the institution can be covered up by the institution authorities, administration. But in the practice, you have to bear the brunt. There may be medical legal hassle, there may be patient violence. The violence is increasing nowadays, and with so much atrocities towards the hostility rather towards the doctors. So that is I think in every part of the country, we keep listening to those news. Then comes the good backup of academics in the institution. That's true. In institutions, so you have got a library, you have got a journal subscription, you have got a classes, seminar, journal club. Those are good backup of academics. So it is natural that the academicians from the institutions, they are more, they tend to publish more rather than the practitioners. So this is the comparison. But if you ask me, I've done both. So I will say you are comparing with your academicians, but there are advantages of private practice also. Why you don't look at it? See, keeping the advantages in hand, you should go for the publishing. The first advantage is that you are one's own boss, and there is no need of following hierarchy system. This is a very valid point, considering the mental stability imparted by this type of feeling. I'm sorry to say, but it's a fact. It's honest confession. Sometimes, there are two rules. One is, the rule first is boss is always right. And second is, if ever in doubt, go to number one. So these are common things. But in many institutions, you have to please the boss. You have to please the boss, you have to please the HOD. Sometimes the HODs are really good. I appreciate that in my term, I got a very good HOD. She always, encouraged me, but it's not the same thing, cannot happen with everyone. So, but this advantage of private practice is there. You are when on boss, there's no need of following the hierarchy system. And there's a flexibility in work timing. Suppose I'm a professor and head, I've got a fixed time, but I have to attend a college during that time. But you can always alter your cases according to your will, according to the surgical fraternity companionship, and according to the the coming of the cases. And the choice of a hospital or nursing home. I want to work in a medical college. How many medical colleges in the city? I think Hyderabad, I don't know exactly. There may be 5 or 6, or maybe more than that. I don't know exactly. But the choice of hospital or nursing home is, a very, very, very wide criteria for any private practitioner. They've got a choice. And most importantly, they've got a choice of a surgeon. In medical institutions, invariably, we have seen many times there are conflicts between the surgical fraternity and anesthesia fraternity. But when you land into private practice, you have a choice of surgeon. You can always choose. I don't want to work in this nursing home. I don't like this surgeon's work. I don't like his temperament. I don't like his surgical skills. So he has a choice of surgeon. And there's a more autonomy in professional decisions. That's good. But provided it is for the safety of the patients. And habit of self-work and enhanced confidence. See, again, I will say this thing, because in many institutions, when the teachers get seniors, they get more of a supervisors and a teacher and administrators. But in the practice, you always do your work yourself. You always get the cases done yourself. And that really enhances your confidence. And that's a different learning curve. I'm telling you, that's a different learning curve. You see the cases, not from the PG's point of view, but your own point of view, because you are working for yourself, for the safety of patient, as well as for earning yourself. Financial worry, I don't think so. The more you work, the more finance you earn. Practice. This thing is very important. The interpersonal relations become very good. This I appreciate in practitioners, especially all the anesthesiologists in our country. I've seen almost in many cities, there were very good interpersonal relations with nowadays. I've seen among their anesthesiologists, as well as with the surgical or gynecological or ENT or ophthalmological, any fraternity. Very good relationships. And more importantly, why? Because they acquire the communication skills during their lifetime. This is the chapter which has never been, discussed, never been taught during our graduation or a post-graduation career. But in anesthesiology, this has got a huge importance, especially in the intensive care units, at least when you are breaking the bad news. So communication skills, how you really communicate with the common man, that's very, very important. And in their own dialect, in their own, should have both sympathy and empathy. And I think I rate practitioners on a whole, as a whole, not because many of my teachers, they are very good communicate, they have got very good communication skills. But as a whole, if you see an average, the practitioners have got very good communication skills. Now, again, the practitioners or the PG students doubts and queries. Why not publishing? Why not publishing, or why not attending the conferences? The first of all is that everybody will say, especially the practitioners, that they are not interested in lectures because they feel they are hardly practical so as to be useful for daily work. Suppose this is a truth. If you go for the ISACON conferences or any state CMEs, many times, the topics are such which are not feasible for the practitioners. Those topics are actually chosen by the scientific committee or by anybody, keeping the institutions at a priority. The practitioners are not given priority for those type of topics. And this is a reality. We should admit to that. And that's why they say they're hardly practical so as to be used for daily work. And another point is, why waste money and time when one can easily get credit hours displayed on the certificate by simply doing the registration? It's a fact. Every system has got a loophole. Our system has got a loophole. In Punjab, I will say we have to register 50 hours in 5 years to renew our this registration. I don't think so. What is happening in Hyderabad or in Telangana? But these things, they can easily get credit hours by just registering, paying some money, and that's all. They get a certificate, and which will be utilized while renewing the registration. And another point by the practice is that we sacrifice our practice and rather spend money for attending such events. See, this is very important. A practitioner coming to the conference or a CME, he has to be away from the practice the whole day, and he has to do registration and to do something. So that's another point they want to put in favor of not going for publications. And they say, on the other hand, academicians get leave and their registration many times is paid for these type of conferences by their respective institutions. So they say we are at loss actually. It's a fact also. In many states, it's a fact also. And important question is, they say, is this CME or conference going to improve our status as a practitioner? I will just answer this question right here now. I will say, academicians, we are publishing a lot of research. I've received a lot of research from the Nizam institution, just published last, I think this September issue is getting that article also. It's not about that one article is going to create, a sea change in the academics or research. It's always about small things. Ek Hindi mein kahavat hai na, boond boond se sagar bharta hai. It's just like that. The small researches keeps on adding, and then they will bring out the final result, which really from which the society benefits. So it's not just a CME or a conference which is going to improve your status. It is the regular attending of all the CMEs and conferences which will definitely help in improving your status, in your knowledge, in your attitude, in everything. Then they say, if you argue with them, they say academics not my cup of tea. Same thing I think PG student will say. If the PG students say academics not my cup of tea, then why you have done the PG? You should not have done the post-graduation in this specialty. Academics are invariably associated with anesthesiology. So it's not about the cup of tea, it's about willingness of yours to enter into this arena of publication as well as the research. This is important now. Many times we have seen that the practitioners, some practitioners, not everyone, do have inferiority complex. Few of them are afraid that they do not have that much theoretical knowledge as compared to institutional person. So they do not feel like interacting during those seminars or webinars or whatever it is, because they ask a question, whether the people should laugh or people should say this is a very silly question. So many thoughts come into their mind while asking even a simple question. That's what I want to say. In the practitioner module, there is a one clause. Everybody should ask a question, whether even doubt is there. A small doubt can, bring out a very good solution. But for all the practitioners and for all the postgraduate students, I will just like to say, a good doctor or a good anesthesiologist to be successful in your specialty, one must excel academically. That's very, very important. And after that, you should be incredibly detail oriented. You should know everything in detail, whether it's academic or a practical thing. And you should be skillful at the procedures, whatever performing, whether you are doing a private practice or an institution. You may have ultrasound for the block. I think many practitioners are very good in the blind. I can't discourage that. You can't make ultrasound available at the periphery to at least let the anesthesiologist go for the safety of the patient for the blocks. And this is a fact. And maybe, 10, 15 years earlier, it was not freely available. In Punjab, still there's a PNDT Act, where we cannot move ultrasound from this end to 2 meters. Very strict. So wherever they feel the patient is more safe, they should go for that. If the procedure they are skilled at means the supraclavicular brachial plexus block for the upper arm surgery, I think they should go for it block. Whether ultrasound is available or not, it may, have some complications, but patient safety should be ensured rather than making a patient a guinea pig. If they are good at that, they should go. If they are not confident, then they should go for the other aspects of anesthesia. And the most important part is, which our teachers have always told us, always be calm in stressful situations. And I think our specialty people, they are very, very calm. And I've seen this. I've seen my seniors. I've seen my colleagues. I've seen my juniors also. They are very calm in stressful situations, leaving aside few of them. But that is really a very good, a trait in anesthesiology specialty, which has been taught to us. And last of all, they should be warm and caring to ease the patient anxiety. Whether you are in the pre-operative checkup or in the pre-operative room or in the ICU or the pain clinic, the communication skills will help here. And I here again rate the practitioners higher than the academicians. Not all academicians. There are few academicians who are the teachers, who are the torch bearers of the communication skills, and even the practitioners cannot match them. But warm and caring to the patient anxiety is a must, whether you're in a practice or you're a PG student doing the PhD or your pre-operative room. You have to alleviate the anxiety. And how to communicate, you have to know the patient dialect, the patient's mental aptitude, the patient's age, gender. So many factors are there. This will come with time. They cannot come in the first or second year of the PhD. Scope of growth. I am talking first of all about the practitioners. In the beginning, they visit all the medical and diagnosis centers in ICUs when they pass out. All the PGs, when they pass out, they go to all the medical and diagnosis centers. They get a good job there. But few like to work with the senior anesthesiologist. I think this is a very, very sound decision if they make it. And nowadays, anesthesia groups are there. And what the biggest example in the country is the Exxon group. And that's in Hyderabad. I really appreciate that. That group has done a wonderful job, the anesthesia groups. Then growth should be holistic. This is very important. Don't worry about the income. If you just aim at the income, or you say it should be the part of it, you have to earn the respect and recognition, as I told in the Maslow's need of hierarchy, and academic growth as well. And for PGs, the world is full of opportunities. But remember that. Don't run after money. Don't run into the practice just like, giving spinals and GAs and getting the cases done, running after money. But reason, after 5 or 6 years, you will become more like a technician. You will not be an anesthesiologist anymore. So academic growth is a must, even if you want to become practitioner, so as to make your. And for the constant growth, one must have honest and loyalty should be shown to your specialty. There should be a regular updation of knowledge and advancements. You should always be learning through workshops. And there are short courses nowadays. The fellowships are also there. This is the essence of a constant growth, whether you are a practitioner or academician. And try not to gain work in practice by hook or crook, but by one's own capability and hard work. integrity towards one's anesthesia colleagues is a must. This is a very thing. You respect your colleagues, respect your seniors, and give a due respect to your juniors also. And this is a good thing, establishing one's own center. Nowadays, I've seen the anesthesiologists, they are establishing their own center, calling the surgeons for the surgery. They are taking care of the patient post-operatively. This is a good initiative by many of them. And relative value guide is also available. It is practiced in US, Australia, New Zealand, South Africa, where the remuneration is finalized on the basis of the time of the surgery, the complexity of surgery, as well as the risk profile of the patient. So possible solution and room of improvement. I'm just on to the last two slides. Is practical knowledge sufficient enough? Somebody says the practice, they have given 5,000 spinals. I've given 2,000 epidurals. I've intubated more than 10,000 patients. Is that practical knowledge sufficient enough? No. It has to be backed by your theoretical background, whatever you have experienced. I think it's a different learning curve. You publish it, you experience it, you note down whatever the challenges you face during those intubations or spinals or epidurals or blocks, because you may not be knowing, you may be educating the world about it. The amount of work we are doing in India, nowhere it is done like that. I assure you, even in US or Western countries, these much opportunities nobody gets. And to reinforce it, develop a habit of regular reading, at least 1 hour of regular reading should be given either to the journals or your textbooks, because every time you these journals or textbooks, you will see that this is something new coming up. For everyone, ISA directory is there. Nowadays, you can upload the through ISA app on your smartphone. Whatever the data, whatever the difficult case you have done for your helping your own fraternity, you can upload the data, the complications, reason or whatever the good innovative measure you use, and this will be very confidential. No identity will be revealed, but it will help in two ways. It will help in the education of the fraternity, as well as it will help in imbibing of the data. And publication in a journal is a must. For a practitioner also, I say, you publish in journals, I'm telling you, your practice will go for another boost. As many subspecialties of anesthesia have come up, like airway, obstetric, so many there. Similarly, many avenues to work upon. And if you were to specialize in one field, I think because you cannot be master of everyone, so that is a good way of going forward. I'm in a practice. Suppose I'm in a practice. I'm very good in blocks, or I'm good in airway. I keep attending those workshops to polish my skills further, to go further, and that's way you can add to the the quality of your fraternity combined. And so the most important is IAS is an academic body. Everybody should remember that it's a professional, not professional, but it's an academic body, and it's the only common platform where one can meet freely, can relax, and can feel the part of a big family the same way that we are feeling today. So possible solutions and room of improvement. So it has been clearly, the answer is clear. The reunion of academic and practitioners of that city branch and ISA has to go forward. This has to be done at any cost. The practitioners, the academicians have to come on a common front. And how to bridge the gap. This is the most important, the crux of the thing. So regular attendance of the city branches meet with a new unique case discussion, workshop or hand-on skill. The way I think the Telangana state branch is dealing with the monthly webinars or whatever, I think weekly or monthly for the last 2.5 years, credible. It's a very credible. I congratulate the entire Telangana state branch for that. And active participation in other programs of ISA. I think that was showcased in the Telangana state conference, which I attended. There is no complaint about in Telangana. They are really doing it. And reporting or writing the case when it is unique. Any unique case you encounter in your practice, you or in your PG career, you report or write about it, whether it's accepted in the journal or not. Don't worry about that, but you just write about and report to the journal. And there should be, I think, for my angle, this is another part of my practitioner module. There should be a formulation of academic committee at every city branch. I don't want to go into detail of this thing. I've already finalized this thing. I won't go into detail, but academic committee comprising of the practitioners as well as the academicians that will help in growth of the academics in every city. and make city branch so strong that every time a new member comes, he or she should feel that they're the new members of the family. And to be very honestly, I salute that Axon group. Whenever they, recruit a new person in their group, they make them ISA member. That's really very credible. And I've listened to the stories of many stalwarts and yesteryears where they worked with the ether, the trilene, the chloroform. I'm still meeting those people, and they struggle to bring ISA, not just ISA, the specialty to newer fronts, to newer heights among when it was not recognized at all. When anesthesiologists were not treated as a doctors, that's a motivation. They were working in such a hostile environment. Now we have got equipped with so much, modern equipment, the modern facilities, the modern gadgets. So I think it's a motivation for us. Listen to those stories, you will get motivated. And last of all, a just question for the whole house. This is a severe, case of kyphoscoliosis, and this patient came for, cesarean section, emergency cesarean section with the fetal distress. How to proceed with this case? That's a question to everybody in the house. Whosoever wants to answer, that's fine. So I will just end my talk by saying Jai IJ, Jai ISA, Jai ISN, Jai Hind. Thank you.
That was an excellent talk by Dr. Bajwa. You have chosen a very good topic, which is different from routine academics. This topic will help all the practitioners as well as those working in institutions across Telangana. And thank you for the kind words about ISA Telangana. It will continue these sort of programs. Thank you.
It is really a motivational lecture at every level, starting from the postgraduates, private practitioners, academicians, and all those things. You have conglomerated at all levels of this anesthesia group. So this is a very good, wonderful lecture, and how to communicate, how to go ahead with the recent times, how to mingle with the private practitioners, postgraduates, and motivation is very, very important. Like, definitely it's a very, very good, sir. Thank you, Dr. Bajwa, sir.
Thank you, sir. Sir, any question, any doubt about this talk? I think everybody is welcome for that. Or suggestion or addition to this?
Dr. Srilata, any doubts typed in the chat box? Any questions?
No, there are no questions per se. But I think he had placed a question. Maybe I think we can go for spinal anesthesia for that patient, keeping all the emergency drugs and equipment.
Spinal anesthesia was very difficult. I tried myself, but ultimately you have to give GA to this patient. The spine is so distorted, and the next part is the tethering of the spinal cord. How the spinal cord, how it behaves in this type of scoliotic and kyphoscoliotic spine, where the level ends. Even you may not be able to get through the MRI properly sometimes, because this patient was pregnant. You cannot get all the radiological investigations to be done, for sake of the fetus. And these type of cases are challenging. What I wanted to tell here is, if somebody is in the periphery, get this case and the fetus distress is there. Now, what is more important, saving a mother's life, or you going through the section, attending that patient there, and the most tertiary care institution is almost 50 to 60 kilometers away from your periphery. So these are the real challenges faced by a practitioner at that time. They are all alone. They don't have a modern gadgets. They don't have ICUs. I almost faced the difficulty of expecting this patient 30 minutes. I gave GA, but 30 minutes means something. You should have a backup of ICU, and I had backup. But in practice, how you really do such cases when the fetus distress is there? You cannot, and people will come. Doctor ने इनको बेहोश नहीं किया, surgery और time पे नहीं हुई, बच्चा मर गया, माँ को problem हो गई. There are so violent scenes are there. So these are challenges, only a practitioner faces, and in institutions, people they can't see that challenges coming to those practitioners. That's why I say, if you can refer, if you refer, still there is a problem. They say, why you referred when you can attend that, could have reduced the mortality by attending to that patient. You're qualified. So there are so many questions actually. Very dynamic answers.
Yeah.
One thing to add, sir. We have
Yes, sir.
recently done the similar type of case, scoliosis.
Mhm.
The patient is not able to sleep on supine position, actually.
Mhm.
Scoliosis is so severe.
Same thing.
So we had the same problem whether to go for spinal or whether to go for general. As you have done, we have tried for the spinal. We could get the tap, but the analgesia is quite erratic. It is not the level was not proper because of the scoliosis. So
No,
we
sir,
had the
there's one other point I will just add, sir. You keep on speaking after that.
Yes.
The teething effects of the, the curvature, they got a fibrotic pattern inside the spinal cord and, between the dura. And the drug spreads very erratically in this.
erratic spread. So with the only option was to give general anesthesia, but the problems are compromised pulmonary, and the case has come for an emergency cesarean. We could somehow get out without any problems. Luckily, the patient has come out regular with normal recovery, sir. But we had faced the same problems, similar to those problems you have faced. Thank you very much, sir. It's a very good lecture you have given. The challenges of anesthesiologists in different walks of life and their different types of how do you tackle those challenges. It's a very good, sir. Congratulations.
Thank you, sir.
Dr. Deepraj Singh, sir,
Yes, sir.
you want to add anything?
Yeah. It was very nice to hear from Bajwa all those situations wherein the publication might become a little difficult for the PGs or the private practitioner to present. It was very nicely presented in a simpler way, very simple way. Nice job done, Bajwa.
Thank you, sir.
So general anesthesia is the better, definitely. Okay.
Yeah.
Agree with that.
So thank you, Dr. Bajwa, sir, for coming to IS Telangana webinar, accepting our invitation. So we will.
My pleasure.
Yes. And we had an excellent talk today by you. So we will move to the next session, that is a case discussion. I request Dr. Srilata to proceed.
Yeah, next coming up is the case discussion. We have the topic is anesthesia for hydrocephalus. The problem-based learning discussion we'll have. We have Sumaira from is a postgraduate student from Nizam's Institute. She'll be presenting the case, and Dr. Ravi Naga Prasad, is anesthesiologist from Nilofer Hospital. He will be the examiner and the moderator for this. And I think it's high time we'll go ahead with the case discussion. Sumaira, are you ready? Sumaira, are you ready? I saw you in the...
Yeah, she was there.
Yeah, I also saw her. Sumaira?
She is still there, but I don't know. We have to call her.
I'll call. Hello, good evening.
Yeah. Come, Sumaira. We are waiting for you.
Yeah. Welcome, Sumaira. You can start your case.
Thank you.
Your net connection is fine.
Good evening, everyone. Good evening, everyone. We'll be discussing about a case of hydrocephalus. I'm Dr. Sumaira, junior resident from NIMS. So it is a case of 1-year-old infant named Vedashri, who was a resident from Nalgonda.
Sumaira, the screen
informant is
go for the slide show, Sumaira.
Slideshow. Keep one slide.
Go for the slide. So,
Yeah, one second. Ma'am, is it visible, ma'am?
and
Not
no,
visible. It's not
right now.
visible. It's not visible.
Share your screen again.
Shall I guide her? The same problem I also met.
Yeah. Please start.
Where
Yes,
I just do one thing. You first open that one.
Yes, sir.
This one slideshow. Then on the small icon of the Zoom, then you enlarge it. It will come as a. Then you create a share the screen. First you open your this one slideshow. Then you
Yes,
go
sir.
to, then you go to beginning from beginning. Say from beginning. Go from the beginning.
Yes, sir. Yes, sir.
Click it. On the beginning you click
Yes,
it.
sir. I clicked it.
Clicked it. Now you go to your
Yes,
this
sir. I
one.
clicked it.
Yeah, it has come now.
You
Yes,
got
it
it.
has
You
come.
got it, Sumira. Sumira,
Yes, sir.
can you put on the video so that we have proper coordination?
Yes, sir.
Okay.
Okay. Got it. What happened, Sumera? Check with your net connection.
Yes, ma'am. I'm checking.
Or else you go for mobile data.
Yes, sir. Good evening, everyone. Today we'll be discussing about a case of hydrocephalus. It is a case of 1-year-old infant named Medashri. She's a resident from Nalgonda, informant being mother. The chief complaints were increase in the head size and excessive crying since 1 month and poor feeding since 10 days. History of present illness. Patient was apparently asymptomatic 1 month back, then developed a progressive enlargement of head. It was not associated with fever, vomiting, pain on applying the pressure, swelling in other parts of the body. Skin over the head was stretched, shiny with dilated veins. She also complained that the baby was irritable and crying since a month. Baby was also not sucking well and not taking any oral feed since 10 days and was exclusively breastfed with no supplementary food. It was not associated with nausea, vomiting, pain, abdomen, loose stools, hiccups, fever, seizures, trauma, any other congenital defects or defective vision. Past history, the patient birth weight was 2.3 kgs. The infant was delivered at 34 weeks of gestational age by emergency LSCS because of the preterm premature rupture of membranes. So she was admitted in NICU for 17 days. There is no history of oligo or polyhydramnias or no history of IUGR, and there was no history of any large head at the time of birth. Immunization history, immunized till date, milestones were normal. Personal history were regular as informed by the mother. General physical examination, child was conscious. It was 10 days, height is 75 centimeters. Enlarged head is present. No pallor, icterus, edema or lymphadenopathy. Vital data of the infant, temperature was afebrile, heart rate was 130 per minute, respiratory rate was 35 per minute, BP was 80 by 50 mm of Hg. Local examination of head and neck. So first, when we come to the inspection, we observed that the head was enlarged disproportionately as compared to the body and face. Head circumference was 59 centimeters, chest circumference was 38 centimeters, skin over the head was stretched, shiny, and dilated wings were present over the skin. Anterior fontanelle was found to be bulging. Downward case was present. That is, sunset sign was positive, and there were no signs of any dehydration. Palpation. Anterior fontanelle was open, full, and bulged. cranial sutures were found to be separated. On percussion, over the scalp, a cracked pot sound was present, which represented McEwen's positive sign. On systemic examination, in cardiovascular system, S1, S2 were present and no added sounds were observed. Respiratory system, bilateral air entry was present and normal vesicular breath sounds were observed. On abdomen was soft and there was no organomegaly. In CNS, we observed upper gaze palsy and spine was normal. Investigations of the infant, HB was 9.1 grams per deciliter. Total leukocyte count was 9,000, 4.4 lakh per microliter. Blood urea was 37 mg per deciliter. Serum creatinine was 0.28 mg per deciliter. Serum electrolytes were normal. These RFTs are important because if the patient is having any persisting vomiting or if the child was on any like medical management, there can be a derangement. This is a CT image of the child in the third and lateral ventricles. Though if we summarize the case, it is a case of 1-year-old child presenting with progressive enlargement of the head, crying, irritability, upward gaze palsy, and crackpot sign positive. That is, it was crackpot sound was present on percussion. So the provisional diagnosis is it is probably a case of hydrocephalus, and imaging it was shown to be a congenital hydrocephalus, probably due to aqueductal stimulation. So if this was the case, so we'll have a little bit discussion on anatomy and physiology of CSF and its dynamics. CSF plays a very important role in the homeostasis of the brain extracellular fluid and maintenance of the normal neuronal function. Adult CSF volume will be about 150 ml. Most of it will be produced by the ependymal cells of the chorioid plexus. In intracranial pressure varies according to the age. In adults, it will be around 10 to 15 mm of mercury. In term infants, it will be around 1.5 to 6 mm of mercury. In neonates, it can even be 0. The range will be 0 to 6 mm of mercury. The cerebral perfusion pressure will be equal to MAP minus ICP. MAP is nothing but ICP. If you are not monitoring the ICP, we can even take the CVP in the measurement. The pathway of the CSF, it is produced from the choroid plexus of the lateral ventricle. These choroid plexus are nothing but a villous folds which are lined by the epithelium, and they'll be having a central core of vascularized connective tissue. So the secretion will be an active process. It is an active secretion. From the lateral ventricles through the foramen of Monro, they will be going to the third ventricle, and through that, after that, they'll be going into the fourth ventricle through the aqueduct of Sylvius. Then through the three openings, that is the medial, there will be a foramina of Magendie, and the two lateral openings from the foramina of Lashka, they will be going out of the brain into the subarachnoid space. Now the reabsorption, primarily the reabsorption is through the arachnoid granulations and through that into the cranial sinuses and then into the sagittal sinus. Secondary reabsorption, it can be present alongside the cranial and spinal nerve roots, particularly the olfactory nerve. So this is a...
Excuse me, Sumera. I think Dr. Ravinaga Prasad can... Dr. Ravinaga.
Let her continue, madam. We'll complete after completing her.
Okay, right. Yeah, fine. Continue, Sumera.
This is a small diagram showing that the pathway from the lateral ventricle going into the third ventricle and then the fourth ventricle and then escaping into the subarachnoid space. So hydrocephalus, what is hydrocephalus? Why does it happen? It happens due to the mismatch of CSF production, absorption, causing an increased CSF volume. According to classification, there are two types, communicating and non-communicating. In communicating, again in the classification, we'll be having congenital and acquired ones. In communicating congenital, it is due to achondroplasia and other skull-based deformities. In acquired, it is due to subarachnoid hemorrhage or intraventricular hemorrhage or post-infectious sequelae. In non-communicating, If it is congenital, it is aqueductal stenosis, which is most common, or it can be Arnold-Chiari malformation or Dandy-Walker malformation. In acquired cases, it can be mostly due to tumors or post-inflammatory adhesions or cerebellar hematomas or any infarcts. What is communicating and non-communicating, and why is it important to differentiate them? Communicating is in which there will be a free flow and the transmission of the CSF pressure waves from the ventricles into the basal cisterns and spinal CSF channels. So the important thing is it can be drained by a lumbar drain. In non-communicating, it is an obstructive hydrocephalus. That is, the CSF has been blocked at any point within the ventricular system. So it has to be drained directly by the external ventricular drain. It can't be drained by lumbar drain. Coming to the clinical features of the hydrocephalus, it can present in an acute presentation or a chronic presentation. In acute presentation, the patient can be presented as headache, impaired consciousness, vomiting, seizures, reduced upward gaze, which will constitute a Perinaut syndrome, diplopia, lateral gaze palsy, which will denote a sixth nerve involvement, and enlarged head, which is seen in infants. Sixth nerve is most commonly involved because sixth nerve has the longest intracranial course. There can be sudden death also because if it is a colloid cyst of the third ventricle. On a chronic presentation, patient is going to have a gait disturbance, urinary incontinence, and cognitive decline. What are the investigations?
Sumaira, we'll stop for here.
Yes.
Investigations and all those things we'll discuss about that. Okay. So this is a case of hydrocephalus, which has presented with some signs of intracranial, the eye signs and all those things are present. How do you preoperative? What are the preoperative evaluation and what is the preoperative workup you do for this case, which is posted for VP shunt? How do you prepare preoperatively, Sumaira? Hello.
Sir, apart from the normal routine evaluation, mostly we have to see for any difficult airway, sir. Because generally, as such, in a pediatric population, head will be more in size when compared to the chest. But here in a hydrocephalus case, head is still more enlarged. So the positioning has to be kept proper so that the axis can be like they are in the same alignment.
Okay.
So we
you
can
are
keep
going to
shoulder.
You are going to evaluate airway, one of the important things. Huh? So
Yes,
what are the other things you will look for in examination?
Sir, we have to see whether the patient is having any other associated comorbidities, sir. If the child is a syndromic baby, the patient can have any cardiovascular abnormalities or any respiratory system involvement.
Okay. And another thing is the dehydration, which is important. Huh? Dehydration, you were just talking about the repeated vomitings and dehydration. The patient is irritable. Huh? So these are the things which you look for. And what are the investigations which important investigations which are important for your anesthetic management? What are the investigations which you look?
Apart from the CBP, we should also order RFT, sir, because of the said vomiting.
What is RFT?
Renal function test, sir.
Okay, why?
Because even if the patient was first there is a vomiting history, sir.
Okay,
if
what
there is
are
a
the
vomiting
electrolytes?
and also
what are the electrolytes which are important for you?
Sodium.
Yeah, sodium is one of the important for the pediatric cases, and even potassium is very important. And you should also look for the hemoglobin percentage. Sometimes even a significant small amount of blood loss will produce significant problems during the perioperative period. What is her hemoglobin percentage?
9.1, sir.
Do you think it is okay for her for a one year infant?
sir. No, sir.
What is the ideal hemoglobin which you feel for an elective surgery? Is she anemic or it is okay for her to do for an infant?
It's an anemic child, sir.
It is anemic, but sometimes this infant with 9.1 is acceptable because they have got compensatory. What are the what are the compensatory mechanisms which occur during anemia? Huh? You need not any compensatory mechanisms which occur in anemic patients, like ODC curve shifting to the right. Huh?
Yes, sir.
2,3 DPG, increase in 2,3 DPG. All these things occur. It is a physiological anemia which is compensated at this age of infancy. So you should also learn about what are the compensatory mechanisms which occur in an anemic patient, like right shift of the ODC curve to the right, or increase in 2,3 DPG and all those things. So 9.1 is okay. But you should also, if there is any significant loss of blood loss, you should also arrange for the blood. So, okay, what are the anesthetic challenges for this patient? See, this patient, this hydrocephalus baby is a short case for you. In a post-graduation, it is a short case. It may not be a long case. So you should also try to highlight the important points. These are the questions they'll ask. What are the anesthetic challenges for this baby at the time of while giving anesthesia? What are the challenges which you face?
First, we have to try to avoid the rise in ICP, sir. Already there is a raised intracranial pressure. We have to try to avoid the raise in ICP, and then we have to also see about the fluid management, the positioning of the patient. How is the positioning of the patient, and we have to prevent hypothermia also, sir.
Okay. Do you have any anticipatory airway problem? Airway problem you have evaluated. No, airway problem. Intubation is also a problem for this child. Okay. So what are the analgesic options you have for this patient? Do you give a narcotic? What narcotic you will use? If you don't give the narcotic, what is the supplementation you will give? Can you give narcotic? What is the issues of narcotic analgesia for these patients?
Already, sir, if you are using narcotics, actually it depends upon the sensorium, sir. If you are going to use narcotics, it will depress the ventilation and thereby again increase. There will be more increase in the ICP, sir.
Right. What is the option for you? How do you manage the analgesia for this patient?
We can give IV PCM at 15 ml per kg, or we can keep a suppository also, sir, at 30 mg per kg, or we can even give a local infiltration at the site, sir, with 0.5 bupivacaine at 3 ml per kg, sir.
Okay. So what are the intubation options? How do you intubate this child? You will give how do you intubate this child? Induction and intubation.
IV induction will be better, sir, when compared to the inhalational induction, sir. Because
why do you prefer IV over induction?
If you are using an inhalational agent, sir, inhalational agents at a MAC of more than 1, they'll be increasing the cerebral blood flow because of the vasodilation, and thereby again increasing the ICP, sir. So it's better if we avoid inhalational agents, sir.
Okay.
IV anesthetic would be a better choice. Propofol would be better, sir. We have to try to avoid any intubation response. Avoid ketamine in this because ketamine also causes a raise in ICP. And succinylcholine can also cause a raise in ICP. So it is preferable to use non-depressing drugs, sir. But if the patient is having continuous vomiting, the patient can be at a risk of aspiration. In that situation, we have to follow a rapid sequence intubation protocol.
So there
at
is
that time, the raise in ICP.
It's a daisy situation.
Can be.
it's a difficult situation where you have to do induction because of induction with IV induction because of the propensity of the vomiting also. There is increased incidence of nausea and vomiting for this patient. So you have to do IV induction and intubation. With intubation you will do with non-depolarizing or depolarizing?
With the non-depolarizing.
So if there is a difficulty in airway, no, then how do you manage?
Sir, and if there is a difficulty in airway, or even if the patient is at the risk of aspiration, if we have to follow the rapid sequence protocol, this
then how do you tackle the difficulty?
can be used because it's rise in the ICP. It can outweigh the rise in ICP due to intubation response.
So what will you do? What is your preference, non-depolarizing or depolarizing? Hello, you are unmute. You are muted. You have to unmute. Yeah. What is your preference, Sumaira? Non-depolarizing or depolarizing for this patient? You will use
non-depolarizing drugs.
So after intubation, what are the problems in the intraoperative period?
First, the positioning, sir. When we position the patient, we have to see that there won't be any extreme rotation, sir. If there is an extreme rotation, again the venous return can be hampered, so that the perfusion of cerebral perfusion can be impaired, sir. First, we have to, when the position, we have to be careful, sir. And also the important thing is hypothermia, sir. We have to avoid hypothermia also in these patients, sir, because hypothermia can lead to a wide variety of problems. They can increase our oxygen consumption, and they can cause coagulopathy because of altering the coagulation status of the infant. They can cause peripheral vasoconstriction or reduce drug metabolism. There are multiple problems which are associated with hypothermia. So we have to avoid hypothermia, sir.
How will you avoid hypothermia? How will you avoid hypothermia?
Sir, the hypothermia, sir. Actually, sir, the first main thing is we have to maintain the operating room temperature, sir. There are multiple levels through which the heat can be lost, sir. Most commonly, it can be due to, in anesthetized patient, it will be due to a radiation, sir. It is nothing but a radiant heat loss, which is due to the temperature difference between the patient and the environment, sir. So
what measures you will take?
Maintain the OT temperature between 27 and 30 degrees Celsius, sir. And for reducing the conductive heat loss, we can cover the patient, sir. We can cover the patient. Okay. And we can also use radiant heaters, sir, but they can also cause burns. So we can avoid those. We can use reflecting blankets also, sir. They are nothing but a plastic foil with an aluminium coating. Or we can use a skin warming device, sir. In this skin warming device, this is best, sir. Like we can
added
use
to that, you should give heated some warm fluids whenever you use warm fluids. That also reduces. So the other thing is you were telling about the one is analgesic. You can use analgesia, but a little lower doses of analgesia. You can combine fentanyl with the non-narcotic like paracetamol. Fentanyl can be given, but not up to the level of 2 mics or 1. You can give 1 mic per kg body weight of fentanyl with paracetamol and local anesthetic. The third one is scoline is not contraindicated. Scoline can be done. Suxamethonium intubation can be done. But if you are confident that there is no anticipatory or airway and everything, a modified rapid sequence induction can be done. Okay. Yes, so these are the 3 things. Then during the if there is sudden loss, how do you manage the perioperative fluids for this patient?
As the child is an infant, sir, we can follow the holiday sugar formula, sir. The child is 10 kg. 10 kg weight, so 4 ml per kg of the weight we can give, sir. But
Okay.
in an infant, they are more prone to become hypoglycemic. So the glucose requirement of around 4 to 6 mg per kg per minute.
So
Generally, we'll
what
be
is the
adding
ideal fluid?
20 ml of
What is the ideal
NS,
perioperative fluid?
NS, sir.
NS. But what about your hypoglycemia and you will give anything added to that? NS can be given. What is the ideal perioperative fluids for patients in pediatric patients now? NS is isoelectric or iso or hypotonic?
Near to our plasma osmolality, sir.
Okay. The
So
ideal
for
thing is
preventing,
you can use the ringer lactate with 1 to 2% dextrose. Even for all the cases of pediatric patients, the ideal fluid, ideal perioperative or intraoperative fluid is ringer lactate with 1 to 2% dextrose. It can be prepared. You take a dextrose, the burette set with you can prepare 80 ml of ringer lactate with 20 ml of 10% dextrose. That you might have seen in Nilofer, no? When you're
yes, sir.
posting.
20 ml of 5D will be mixing in the 100 ml of the fluid.
Not 5D. 5D will not produce 10% dextrose, 20 ml in 80 ml of ringer lactate will produce 1 to 2% of dextrose. That is ideal.
Okay, sir.
So, what are the problems at the time of is there any chances of delayed recovery for these patients, and why there will be delayed recovery?
Most common thing will be the hypothermia, sir.
Okay. Any other causes of delayed recovery for these patients? The delayed recovery may be your atracurium may be a higher dose. You may try to give a higher dose because the weight of the head is larger. It is the majority of the body's weight is head weight. So if you give atracurium of the dose of 0.05 or whatever is there, you give mg per kg body weight, it will be very high. The muscle mass is very less. So you should be guarded in giving the long acting also. Or non-depolarizing muscle relaxant also, you should be guarded by giving atracurium or whatever is there, whatever long acting you give, because it will become larger because the muscle mass is less. So there will be delayed recovery. So you should also look, you should be very guarded while giving the delayed patient with it. So what are the other complications during the post-operative period?
Infection, sir.
Now, before that infection, post-operatively, what are the things you should look for? The patient may have apneas, hypothermia, apnea,
Yes,
and all these things have to be taken care. There might be sometimes respiratory apneas, hypoventilation during the post-operative period. Okay.
yes, sir. Yes, sir.
So these are the things which you should look at so how do you should have to put the patient, warm the patient during the post-operative period, and you should also monitor the saturations and the respiratory rate. They are more prone for apneas, post-operative respiratory apneas, which you have to try to monitor and properly do it.
Yes, sir.
So, finally, this is a question of this might come for a short question. Short. It's not a long case. It's a short case. The short case you have to give only the gist of the important clinical findings, which he will ask only for because it's only a 10 to 15 minutes. You have to highlight all the important points in the history, and he will ask the examiner will ask only the management of the cases. For short cases, you will be asked only the management, preoperative management, preparation, and postoperative complications. It's not a long case. So,
okay, sir.
I will hand over to Srilata, Dr. Srilata.
Sir, shall I add a comment here?
Yes, sir. Yes, sir.
I really enjoyed this interaction.
Yeah.
As if my examination was going on, I was on this Sumera side actually. How to answer these things. It was not a short case. It was actually answering like a long case only, not a short case. And beautifully. And the way actually I like the interaction. A teacher should interact to the students like that only. The motivational factors, because the lecture was aimed at that only. The way you motivated her to answer, you brought out the answer. She knew the answers. The way I really like that thing.
Okay, sir.
So
Because I want to give some benefit to other postgraduates who are listening.
That's the way the people sitting in the in that panel, as well as who mostly watching on the YouTube. This is the way to take an examination. Tell the student to come out. You can't just be sadistic to the student during examination. It's a very good way. That's the way to ask a long case or a short case or whatever the viva we always ask from the student. I really like this interaction. I was impressed by both of you. First of all, Dr. Ravi sir and Sumera also. She really, answered with the full confidence. I really appreciate her teachers who have made her, so much self-confident that she could answer like that.
Yes.
Good, Sumera. I really appreciate you.
There is a
Thank you, sir.
dear Sumera, you missed some of the points in case presentation, like heart rate 138. You told, is it so? Usually, it won't be. And you said rapid sequence intubation. It is not possible in these patients. Already, it is very, very difficult. And you should take the help of the senior anesthetist. You should have 2 members for anesthetizing the patient. And if you have all and intravenous line, where do you take? Also, it's very important.
There is one important point here. Sometimes these patients do not have intravenous lines to the limbs. It is already. So sometimes in very rare occasion, you have to, the only prominent lines will be on the head.
Scalp.
So there are some rare, but it is very not ideal for the person to secure a scalp vein. But there are some rare occasions where you have to secure a scalp vein and use the patient and then go for a peripheral line. Dr. Veeresham and we worked together in our post-graduation days, and we had difficulties sometimes. Do you think, Dr. Veeresham, we had difficulty in securing IV line?
Definitely, 100% we had a difficulty, especially in pediatric group. And we do find it happened then every alternate patient will have that problem in pediatric group. That is it, but the way presentation was, it is like a lecture. It should not be like a lecture for you as a postgraduate. It's a case presentation. It should be like salient points, and it should not be like what is the real invention. You did not answer. Electrolytes are the main important. See, Ravi Naga Prasad is extracting you from so many corners. Okay, anyway, it's the next point. It is not to discourage anybody, but go ahead. And in future also, any case presentation, it should be like what you have done in that case. That way you should present. What I have done, that is important. Okay, thank you. Thank you. Don't think
Thank you,
otherwise.
sir.
Yeah, just to add some points maybe. And other thing like discussing about placement of IV cannulas, it's not always practically possible. Theoretically, it's always good to say that IV anesthesia is preferable, but practically no patient comes with an IV line.
Yes.
So sometimes we induce with inhalational because the patient will be, if you're placing IV cannula, the patient will cry. Then again, that is again the vicious cycle of increased ICP. So induce with inhalational agent and secure an IV cannula as soon as possible, and try to decrease in inhalational agents as far as possible.
That is an ideal way.
That's what practically done.
But normally, majority of the institutions, more so in the pediatric institutions, they will secure a good IV line because preoperatively they give an antibiotic, a dose of antibiotic, and even they start fluids. In majority of the pediatric, even Nilafar Hospital, which is a very, very busy hospital, also
already when IV line unde ante obviously will start with an IV line, And if IV
That's
line is
there.
not there, then inhalation.
The problem, like Viresham, which I highlighted, securing an IV line is very difficult. And if IV line is not able, we are not able to secure better to start with sevoflurane, a dose, small dose. But as Viresham was telling, you require some or 2 or 3 assistants for a pediatric case.
Yeah, that's true. Without an assistant, you should not go for it, actually.
I feel
just one comment.
Yes, sir.
Is, sir. That's what I call the bridging the gap between our generation and the newer generation. That was you were very much right in saying that these cases should be done in the pediatric institutions. Nowadays, sir, what the IV lines we used to secure, we always used to say we are masters of securing IV lines in pediatric patients, whether it's a hydrocephalus or any abdominal tumor or somewhere. We used to find the lines in the arms or legs or somewhere else. But nowadays, what's happening? The advent of the ultrasound has made it so easy to secure the central lines wherever it's possible. I attended that Noida seminar in the pediatric institution there. So they used to secure the line in every such cases where there's a difficulty in securing the lines, and that's really important. That's how we should get these cases done in the highest specialist center, where the people can always get access to the central line through ultrasound or through some other mechanisms. I think that's the way to go forward. I think we were the people who used to secure. Okay, we used to feel glory that we have secured the IV line and that thing. But I think those days are gone. We should admit to that now. With the new equipment, new technology, new things are coming up now. This is just my humble submission to the house.
Yeah, that's very true.
Absolutely, sir. I will I'll give any postgraduates who are here to have any doubts. You have any doubts or you have any inputs regarding the this case, hydrocephalus case? Anybody? Anybody can open up. I think Anusha has come to Nilafar Hospital. No, had she seen any hydrocephalus? Nowadays, actually, in Nilafar also, they are all the hydrocephalus cases are going to neurosurgical ward. Have you seen Amma? Have you come to Nilafar?
Anusha,
Divya is there.
Anusha is from Medicity, Ramakrishna.
Yes.
Yeah, she has come to our hospital. I think we have
one Anusha.
Dr. Anusha raising his hand again.
Viresham, sir.
He has a lot of doubts.
Itself, whatever you told is correct. Ultrasound, so many gadgets are coming. Actually, we have to reinvent our procedures. How to come over whatever budget.
Yes,
learning skills, new learning skills, sir.
Yes, that's what we have started using and learning in elective cases so that we can use them in this.
That's what it is. No panic in emergency cases.
Yeah, that's true.
Deepraj, sir, anything to be added?
Yes, Ravina Prasad, I have seen sometimes children with very large head for the size of football. There, it's very scary to even to think of any IV induction. We have gone for big intubation in such cases where there is a really very large head. Probably once you give IV induction agent or the sevoflurane, the airway may be lost, especially 3 months baby with very large head. So there we have gone for awake intubation also, where the IV line is already there. So that is one thing, and adhering to the principles of pediatric anesthesia. Probably that is the main crux of these surgeries. Strictly adhering to the pediatric principles of pediatrics. And there are different techniques. There are different techniques for intubation also. We used to ask in examination for PGs who come for these cases as a short cases. So how do you intubate? What are the different techniques? How do you take the help of your other colleague? How do you support the head? How do you support the body? All those things to just ask the postgraduates during their examination times. These are
Sumaira, do you know how to intubate this case? Very large head. Have you seen it?
the position is very important. How to
So, Sumaira, actually, if you have there's a big, larger than this head, somebody has to support the head at the edge of the table, and then you bring to the head to the level, and sometimes you have to do or a lateral intubation. Sometimes you put the patient in the lateral position and try to intubate, but all these things are definitely anticipatory airway problem, and you have to plan properly, and you have to keep everything. A small stillet, the stillets which are used for the adult cannot be used. There are some small stillets available. Sometimes stillets are very much useful. You might have seen in Nilafar Hospital those small stillets for the 4.5 ET tubes. We use stillets, but it is very rare. The other things are airway management at the time of mask ventilation. Sometimes mask will not fit properly for these patients. So you have to properly identify a good mask and then a appropriate mask. I would like to say appropriate mask, and better to pre-oxygenate these patients, because pre-oxygenation does reduces the desaturation at the apneic time. So.
Folded towel may be kept.
Yeah, that is one of the a folded towel has to be kept.
Sir,
Make the
sir,
surface.
We were also told like that to keep the head in
Ring.
the lap with two
Yeah.
assistants by side.
Yeah.
Teachers, I think 2 decades back I'm talking
Yes,
about.
yes.
That lap also used to be very good, you know, somehow with a pillow between your legs and putting the head in the lap for all the hydrocephalus cases.
keep head hanging.
Head hanging is
Head hanging.
yeah, we normally in Osmania we used to do head hanging, hanging at the edge of the table, and one person will be intubating and one person will be helping.
Sir, bridging the gap between the older anesthesia techniques and new techniques.
Osmania theater we used to do like that.
Yes, exactly.
But anyway, either of the ways we can do. Either we can raise the body with the help of towels to bring the same level, or we can pull the body to edge of the table.
Yeah, edge of the table is not usually stable. The head will not be stable.
No, somebody has to help, Dr. Vireshan. We have some person has to sit down and help and hold the tape. But it's definitely it looks very risky and scary, but it helps sometimes. Sometimes a big head, very big head, sir. It helps sometimes.
Sir, how about using fiber optic intubation?
Sir, actually, yes, all these advanced techniques have come a lot. If you plan for a fiber optic, you can go for a fiber optic. Sir was telling awake intubation.
Awake intubation, fiber optic intubation of that size, 3 millimeters and low.
No.
Very rare. Sometimes big institute also will not have that size.
That size ET tube.
No, possible with the fiber optic, sir. Fiber optic, usually you get with the 4.5, sir. 4.5 you get. What you can do is a pediatric video laryngoscope also. You can
yes, sir.
Pediatric video laryngoscope.
Yeah. Okay.
Fiber optic will not work out in 1 year, less than 1 year.
Less than 1 year, it is very difficult. You
This
may get
patient
the
is,
equipment.
Actually, I think Sumaira has opened a Pandora box.
Okay, thank you.
Sir, can place a guide wire just over the vocal cord, just place it, and we used to pass a guide wire if such cases.
We used to do like that only.
Yeah, that's what. So that is what a lot of big Pandora box can be opened.
Okay, sir.
I think we had a fruitful discussion today.
Yes.
I thank Dr. Bajwa for coming to the webinar, and Dr. Ravina Prasad to accept our invitation to be examiner. And I congratulate Dr. Silata for managing the situation very well. Thank you all. Thank you for attending the webinar.
Sir,
Thank you.
I just want to say one word before that. Shall I?
Yes.
Yes, yes.
Okay, sir. Actually, what happened? We took the journal in 2020 when actually we just preparing for the first issue of March issue, the COVID struck, and that time, this lecture is based on that only. The publication matters. Parish publish or parish, the promotions, the presentations, the NMC guidelines or MCA guidelines were like that. So we came out with the supplements so that we can have more avenues for publication. So at that time, the journal was ranked 68 in the world among all the NSC and pain journals. Dr. Lalit's visions and our team's hard work, the editorial team hard work, we brought the journal to almost a rank of 31 in the last 2021 February, the ranking. The 22 ranking will come in the next year. So it has now ranked 31st in the world, the IJA. So everybody should be proud to have a publication in IJA, whether it's a letter to editor, a clinical communication, research article, anything. And the impact factor, the projected impact factor is 1.53. It is, I think, one of the best in India because it was 0.7 around 3 years back. Now it's 1.53, and we are expecting it to be 2 next year. And the journal has moved to the Q1, that is quartile 1 of the rankings. And India, the whole universities everywhere, the whatever the requirement is, that is the journal. Your article should be published in the Q2 journals. Our is in the Q1 journal. So our IJ is a very, very, highly profiled journal now. It's matching with other journals. It has come. British Medical Journal is below that. I'm telling you, BMJ is below our ranking now. So in the another year, I think by another February, next February, we will be ranked very high. So what I request everybody, the practitioner, the PG students, the teachers, try to give a quality work to IJ. We are publishing the quality work, and it will, definitely enhance the reputation of our Indian Journal of Anesthesia as well as our own anesthesia fraternity. That's my submission, humble submission to everybody. And we will be, I think, striving together all in a combined manner. The ISA and IJ have done very good work for the last 2-3 years, and we should continue with that. That's my submission, my request, and that's my, everything to all of you.
Thank you, sir.
Thank you, sir.
Very much.
Thank you, sir.
Thank you very much.
Congratulations.
Thank you.
Thank you, ma'am.
For
Bye,
IJ.
bye.
IJ.
IJ. Okay. Thank you.
Good night, all.
Good night. Good night, everybody.
Thank you. Thank you.